All right, thank you guys. So I'm a child psychiatrist, and so we in our clinic are constantly thinking about ways in which we can kind of augment our way of getting information about our patients other than that kind of self-report in our office. And so this is really intriguing, and I think all four of you did a really nice job of showing ways in which this can be very beneficial and also raising all of the questions and kind of around ethics that come up as well. So in the interest of time, why don't we get the panel started so we can really dive into some of the questions that you raised. So I'll invite all of you back up here. Is this on? Excellent. So I'll start by asking a few questions, but then we'll open it up to all of you to ask some of the questions that came up for you as you were listening to them speak. And so, again, one major theme that came up amongst all of you was the ethical dilemma that we face here. And so, I was wondering if you can speak a little bit more to, because we also see that clinicians are already using this in their practice, and so we can't necessarily wait for everything to get very clearly demarked for us and set out. And so, what are some of the biggest kind of privacy or confidentiality breaches that we as clinicians are at risk of in engaging patients' social media? Benji, yeah.
Happy to take that. I mean, I think you're absolutely right that people are already kind of using all kinds of technology, you know, and I can tell you because of what my day job is that I get to see all of these breaches that happen, and the irony is they're not the complicated ones oftentimes. You know, it's I put someone on a CC line instead of a BCC line. I mean, it really is something as simple as that creates, you know, privacy breaches. I think what we're talking about here is very big scale, other interesting kind of complexities. But what I think about is often just habits, essentially. So one of the biggest things with technology, right, is that we do everything reflexively, right? So we reflexively go and put everything into Google to find the answer. We reflexively just start sending off emails or text messages. That we just kind of automatically do these things. And in the medical context, that's not necessarily the right way to be handling things. And so I think trying to not be reflexive, trying to take a break, really think about, well, how am I supposed to be handling this, and developing kind of like, you know, ethical habits. You know, Aristotle used to talk about ethics having good, virtuous habits, basically. So I think just having good habits where it's like, I'm thinking about where my data is getting backed up to, and I know that it's not getting backed up to a cloud that it's not supposed to be getting backed up to, and just the daily habits, I think, are the things that people get themselves in the most trouble with, basically.
So I think some of the challenges that we have faced are twofold. So one of it is around secondary consent, and I think you touched on that a little bit, Benji. So a unique thing about social media data is it's just not my data, right? It's all of my friends' data as well in some shape or form. It is complicated by the fact that I may consent to sharing my data, but I have not consented, there is no consent from you, I don't have that. But you may have liked one of my posts or commented on one of my posts, so how do we navigate that? This is complicated by a second issue, that it's true de-identification, unlike other kinds of data, is never possible, because you never know what people write in this post. Like, it could be their birthdays, it could be all kinds of PIIs, it could be all kinds of PHIs. I mean, it's just any kind of sophisticated cleaning you do, you can never get rid of all this automatically. And manually doing that is not possible when you're looking at that kind of scale. So, like, secondary consent and the challenges of de-identification kind of really complicate it. And another thing that I think is a big challenge is the idea of somebody watching you. When you do these studies longitudinally, what happens? Do people change their behavior because somebody's watching them? It's the observer effect or the Hawthorne effect. And when we start to integrate these things in a longitudinal fashion in patient care, the question is, if people start to change their behaviors, then we are no longer seeing the things that we should be seeing. And this is a huge problem going forward.
That's a really good point. Absolutely. That leads to, I mean, again, that's a very interesting point, especially as we as clinicians do tend to sometimes ask, and we have to pay attention to how we're impacting our patients' behavior just alike. And that being said, how far do you think we are from kind of movement or being in kind of this kind of more thinking mode and collecting data to actually more deliberately implementing? Again, given that so many people are informally doing it, how far do you think we are from actually having some more standard of care related recommendations, and kind of what steps do you think need to happen for us to get there?
I can take that one. I mean, it would seem that organically the process has begun already. I think that the work that needs to be done next is sort of studying it and systematizing it. I think there is evidence to be collected around what information is useful, what information is not useful. I think that will guide the streamlining of the process of incorporating these data into clinical care. Benji said it well, that patients have a skill around not telling you the things that you need to know. I think data like this can enhance the therapeutic process by letting you get past the barrier. But I think once we have a better sense of what is useful information and what is not useful information, we will see coalescing of practice around data like these. And I think that's what will guide best practices and treatment guidelines and things like that. And I think once we get to that, that's when we can say that this is now getting closer to standard of care. I do think, though, that sort of the flip side of that coin is, in many ways, there is a distinction between how you handle data like this in the research context and in the clinical context. I think a person may be very reluctant to let a researcher extract 10 years worth of text messages, whereas in the context of therapy, if there was an issue that depended upon it, a patient may give you the phone and say, see what you like. I say this with confidence because it has happened to me. So I think in a one-on-one doctor-patient dyad, we're a lot closer to this being an accepted part of care than we are as a field overall.
Yeah.
To add to that, also we've seen that a lot of these models are not as accurate as we want them to, or we don't, as Munmun rightly put it, we don't really know what is the right level of accuracy for these models to be actually deployed in a real-world setting. That said, these models really give additional data points which help the clinician and patient dyad, and they can sort of give you a risk assessment, say in the past 30 days, you have a 50-minute session with your clinician. So in the past 30 days, what all has happened, and how best to summarize that in a meaningful way. Mm-hmm. That's something that I think these machine learning models can really get to.
Yeah, no, that rings true for even as clinically, right? When you might see your patient once every month or every three months if you're a psychiatrist, and even as a therapist, maybe every week, there's a lot of life that happens in between. And so you can see how it would be very intriguing to collect information about what's happening. And again, at the same time, if your patient knows that's happening, how might that actually impact it as well? So.
Yeah, so to add to what was just said, I think in our work we have seen that patients are overwhelmingly willing to share their data, and clinicians are willing to look at their data. But how exactly that would happen, that's the piece that yet needs a lot of research. And David Moore talked about user-centered design yesterday, and I think that's what we need. We need to figure out what these tools would look like, whether it's in therapy or as a part of care, or a part of somewhere else in the service system, and it needs involvement of all stakeholders, to be honest, to really know what is it that they want and what is useful. And to be honest, I don't think there's a universal answer to that. It varies by the patient, it varies by the illness, it varies by all kinds of other factors. So I think those are the pieces that need to be figured out going forward.
Yeah, no, that makes a lot of sense. And again, I could see the complexities also in kind of looking at things in aggregate and how to kind of then boil it down to kind of the individual person sitting in front of you. So, we can also open it up to audience questions.
That was a terrific panel. I'm a researcher and a clinician, and perhaps a little bit of a Luddite, but I agreed with a lot that Dr. Silverman said, and I can't imagine a scenario where a patient would say, I give you permission to look at some certain amount of my social media data, and that I would think that that would be a good idea. I would want to discuss with them what they think that that would accomplish. What do they think is in there? Are they sure that they want me to know everything? You know, there are reasons that I shouldn't know everything. And also, now then I have data that I have to figure out how to bring up with them to discuss, and I have a lot of data to do that. And I think that can get in the way of the therapy, and it's important what people decide to tell in that process. So maybe I'm just old-fashioned, but I just really can't imagine very many scenarios where that's a good idea. You know, even in terms of risky behavior, that makes it even more problematic for me. I just wanted to put that out there.
So I can go first. I think my view is that what Mona just said, that, you know, how do you fill in those gaps? The clinician is not seeing the patient every day, every moment, but there are stuff happening in the patient's life that could be valuable. How do we fill in those gaps so that the next time when the patient comes in, they have a better, the clinician has a better handle on what may have happened. And you're absolutely right, just seeing raw data may not be as useful, and it has this whole other set of problems around secondary consent and de-identification and whatnot, and, you know, things like sexual data, who wants to see that? I think we need to figure out what are right ways to show that data. Yeah.
I think both can be true, though, right? Because there can be times where, so I've had this experience where I've had a patient come in right after an enormous fight with somebody who's important to them, and so they come in this very emotionally dysregulated place, and then everything they're talking to me about is through that lens, and then I talk to the parent, and they're like, oh no, they've had a beautiful week, and right, but this is where a parent has a good sense of what's going on with the child, right? And so just kind of trying to think about multiple different ways to collect information, not saying that this is going to be the sole way, but saying, is it possible that this could give us something of value? But again, you're right. How do we do that without interfering with all of the other pieces?
So one way we've tried to get past this barrier that you've discussed is, we're trying to have both the patient and the clinician in the loop when we're actually trying to give them the personalized snapshot. So for example, Lauren and Andrea, they've been doing a lot of work in terms of interviewing providers to know what they would really like to see on a snapshot to then be used for case conceptualization, which might be helpful, and we've interviewed a lot of providers who've had mixed reactions. Again, not everybody is really keen to look at these data, but a lot of them think that this would help them in the initial phases of case conceptualization, and also to get a lot of background on the patient.
And I'll just jump in quickly. I totally appreciate the comment, and you know, what comes to my mind is actually what Bruce Kupfer said kind of toward the end of his talk, which is that some of this ends up requiring us to change our roles, and so it may not actually be a therapist, right? And this is kind of what I was alluding to at the end, which is that, right, so right now, if you were to go find a traditional Freudian psychoanalyst and you talk to them about doing CBT homework with their patient, they'd be like, well, no, I would never do CBT, that it's just like they're doing two different things, actually. And so what I could imagine is that as this evolves, this may be a type of therapy, and maybe it's not even a therapist. Maybe we call it a different role, or we call it something different, and that the traditional therapies that work in the way they do may end up continuing to work in the way they do. I don't know, but that's kind of one of the ways that I think about this sometimes.
And then I'll add a last piece, and it's basically echoing what Benji said in his talk. Context matters. I think in the end, all of this is just giving us data, and the data may be hugely important in one context, maybe back-to-back sessions, and not be of meaning in another context. And I think that's where the therapist's judgment comes in. I think the therapist is who can provide the context. I don't think we're that close to an algorithm that can do that for us. Nor do I think it would be terribly healthy if we got to an algorithm like that, because otherwise, really, what's the point?
Just had a quick question. I think that there is a lot of potential here for using social media to get some really interesting information. But one of the things I worry about a lot, and I'm hoping you can speak to, is the issue of sampling. And so for a quick example, with Dr. Guntuku's work, you found that there were these certain personality differences in the people that said that they had been diagnosed. And yet there's like a real lot of research that finds very different patterns in like epidemiological studies that has like more neuroticism and a lot less conscientiousness, and yet you didn't find that. So it kind of makes you wonder, like, who are these people, and do the things we learn about them really generalize to ADHD in general? So just hoping you could kind of talk about that.
So that's a really interesting question, and thanks a lot for raising that. So it's a really different population that actually comes out onto a public platform and says that I have been diagnosed with ADHD or depression or any mental health condition for that matter. That said, even starting with a biased sample, it sort of tells us more about their online behaviors, which can then inform in certain hypothesis generation. Again, we can't generalize just based on these studies, but I think these are preliminary steps to help in finding out newer hypotheses about conditions which are not as well studied as, say, depression, for which we know how it actually manifests online or offline and so on. But with ADHD, it's sort of different frontier altogether. So this is more of a hypothesis generation and hypothesis testing in a clinical setting rather than just generalization to begin with.
Great panel, guys. So I just wanted to ask a question about sort of the burdens of being presented with a very rich set of data that you don't know exactly what to do with. So I'll just say, so as the president of the hospital, in the last couple of months alone, I've received letters that are longer than 50 pages long. So, I love to receive information, but one could say that when I receive a letter like that, right, and we know that in the here and now, nationwide, there are multiple healthcare systems that are struggling with even how you do something as simple as receiving a PHQ-9 and whether or not you really want the item that asks about suicidality, right? Because it triggers a whole set of responsibilities. And so to me, this is such an interesting space because at once we can acknowledge potential access to very rich information, but it seems sort of critically important to me that the standards that we're talking about really have to move tightly in parallel with the way we have these rich data sets. Because if within the rich data set is something with revisionist history as you look back, carries information that we should have known to do something, it actually represents sort of a liability. So I'm curious about just your thought process around that, maybe starting with Benji, but really any of you.
Sure, it's an excellent question. And I assume you're writing 51-page letters back for every one of these. My mind goes to two different places. At the individual level, I think the clinician burden idea, is one of just, it is hard to imagine how an individual clinician kind of could actually receive and kind of deal with all of this data. And I think that's some of what what Ipsit was talking about needing really good kind of like dashboards that present information very clearly and concisely. At a broad level, at the kind of informational level, right, we get, and I again know this because of my day job, that it is true. Every research study that we see, someone does a PHQ-9, I'm going to say, well, how are you going to respond to question 9 when someone answers, 2 or 3 on question 9 of a PHQ-9, and you're going to need this whole suicidality standard operating procedure, and so what are you going to do about every piece of data that comes in? I think it's extraordinarily complex. I mean, I think in some ways, it perhaps goes to a little bit of what I was saying before about the individual clinician role and how that has to change. And I think this is what you were alluding to, is that it almost takes us as a field to say, we are going to have a different obligation when it comes to that level of data. That, if we're giving a standard questionnaire that we know is validated, we're giving a Columbia suicide rating scale that we know is validated for suicidality, we have an obligation to act upon that. If we collect a ton of social media data that might not even be true, it's right, the example that always comes to my mind is when I treated adolescents and they would log into each other's Facebook pages and post things on each other's pages that were just kind of totally false. So if we as a field are going to say, we're going to collect all that data, we may also as a field need to say, and we're going to treat that differently, actually, and we're actually going to say there is no way for us to deal with every single liability point there. But it's a very good question, very tricky.
So I wanted to also add to the changing roles angle. I fully support it. Actually, it reminds me something that one of my collaborators, John Torres, talks about these digital mental health clinics. So the idea there is that, you need to probably think about new types of people who will be part of these digital mental health clinics, whose role will be to deal with this, these digital phenotypes and these new types of data. And it's probably not the clinician because of burden and other reasons. And we probably need to think along those lines of who these new people are and what should be their training, how would they implement those safety protocols and stuff like that. So I think we're thinking of something really different from what we have in place today.
I'll add that if ever there was a nice, tidy role for artificial intelligence in psychiatry, it would be to churn some of these data, process information, and tell us what we probably need to know. Now, I say that as someone fully aware about the limitations of the algorithms and the actual amount of work and needed to get to that point. But to put it in clinical terms, as a clinician, I think I'm less inclined to look at all of a person's step counts and sleep patterns over the past month. I think if that was part of the clinical role, processing those data myself, I guess that's the equivalent of your 50-page letter. You're just as inclined to not look at the phone at all. Instead, if there was a way to be told that this person slept for 3 hours for 3 nights last week, then that's useful and something to act on. Which might be to say that if instead of reading a 50-page letter, if there was someone that tells you this guy's pissed, it might tell you you need to act on this. So I think as data grows, we need more automation behind the processing of data and extracting meaning for it. And I say that while not taking for granted at all how difficult it actually is. But that's really going to be the only way to deal with it, because the amount of data we have to deal with is only going to grow exponentially.
Hi, I was wondering, as all this great research starts to evolve into new technologies or measures, what is the ideal situation for regulation or reimbursement? How do you envision that being something that providers are paying for, or insurance, or is it just, the beauty of a lot of this is that it's free already and it's there, and then there's also this idea of, are you charging patients for their own type of information?
You want me to start? It's a great question. You used the word regulation, right? So we didn't come up at all in the entire talk, but one of the immediate questions is, what is a medical device and what isn't a medical device? And an algorithm that's going to predict a medical outcome and going to give advice that may be potentially actionable is probably a medical device that the FDA may or may not care to have enforcement discretion over. I think the FDA has issued some guidance on these things and tries to, but I think that is a hugely evolving thing still. And it ties into your other question, because how does that impact if an insurance company is or isn't going to be willing to reimburse it? I know we've talked about this in terms of clinician time and the time that this takes, and are you going to build this into standard therapy, or are you going to change it to a 75-minute therapy hour so that you're having time to deal with these things? I think that all remains to be seen, basically. I do think at some point, you know, it's one of these things, actually, Scott Roush and I were talking, I think, yesterday about this, that one of the challenges of our field is that we can't keep up with the technology, right? So the technology is just going to move faster and faster and faster, and we as a medical profession, as medical institutions, government regulation, government institutions, we move more slowly, basically. And so the FDA guidance that was released, you know, is already out of date, basically. And so I do think that there's going to have to be something at some point that the FDA and other organizations come out and really kind of like make a decision about how this is going to fall. And I think that will ultimately probably guide, are these going to be insurance reimbursable things and insurance reimbursable time, or is this going to be a totally separate thing? And then, right, the question of, are you making money off of data that Facebook technically owns is another incredibly complex one that I'm sure they'd want to weigh in on.
All right, we've reached our time. Thank you, everyone, for your very, very thoughtful questions. Clearly, this is not a straightforward issue, but one very worth talking. Thank you, panel. All right, break time.
So let's come back. We're running a bit late, so let's come back at 2:40. So that's about 15 minutes.